Hi, and welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor of JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following on live, you can send us questions at Twitter. Just mention us at JAMA Network Open, or you can make comments in the video windows on Facebook or YouTube. So this is our first episode of 2020. Welcome back. Welcome to the new decade. And we have got a really interesting trial today, the effectiveness of virtual versus in-person inhaler education for hospitalized patients with obstructive lung disease and RCT. And we have first author, Dr. Valerie Press with us. Welcome, Dr. Press. How are you?
Great. Thanks for having me.
Oh, yeah. Yeah, thank you so much for joining us. So why don't you introduce yourself, tell us a little bit about yourself, why you did the study.
Sure. So I'm Valerie Press. I work at the University of Chicago. I'm trained as an internal medicine and pediatric physician, and I do a lot of health services and outcomes research around asthma and COPD. The motivation behind this study was actually a decade's worth of work, so I won't tell you about all of that work, but I'll say that I was initially inspired to study how to help adults with obstructive lung disease manage their disease better at home, based actually on my pediatric training, where I saw that we did a lot of self-management education with patients and their families. So about a decade ago, I started evaluating what the needs of our patients were and found that the vast majority of patients hospitalized with asthma or COPD actually cannot use their rescue or controller medications correctly. And this is not their fault. Even if they have been taught, you actually need multiple rounds of education for skill-based training. So about a decade ago, I started looking at something called Teach to Goal, and it was done primarily then in person, which is great. It allows a trainer to work with the patient to see where the patient is at baseline. Are they pretty good but need a few tips, or are they really struggling? And then they can go back and forth with the patient to teach them how to use their inhaler and practice, basically. We found in several randomized studies that actually works immediately to help patients build their skills. And it even seems to have good outcomes in that within 30 days, using that approach, there were fewer acute care utilization events like emergency department visits or hospitalizations when using this teach to goal method versus just simply telling patients what to do. The one problem with this approach is, as I mentioned, it's skill-based, and so you need multiple rounds of teaching. So what we found is within that same month period of time, that patients actually started to lose their skills. So we developed this virtual teach to goal approach to help both with the initial teaching, if it should be as effective, and then also ultimately, hopefully, for refresher. So this study was a randomized trial comparing in a hospital setting the virtual versus the in-person teach to goal strategies.
Yeah, it's really interesting. In my practice, I do a little bit of casual teaching with patients, and it's hard. And the thing that amazes me the most is that I do what I would consider, I'm not an expert, and I do some pretty basic teaching. And I always kind of preface it with, you've had asthma longer than I've been doing this, et cetera. And I always feel like patients are going to find it really patronizing. And I'm like continually amazed by how much people appreciate it and how much little new things they learn. And the point isn't that I'm wonderful at teaching it. The point is that there's always a lot more to teach. I think it's kind of like, looking in kids' ears. Like it seems easy, but it's actually a lot harder to do than we give it credit for.
Yeah, that's exactly right. And I think your approach is giving them credit for how long they've had the disease and been working with it is a really good one. And then they're probably very open and saying things like, here are some tips and things like that is really great.
Yeah. So what'd you do for this paper?
Yeah, so we randomized 118 inpatients, so they had to be admitted with a history of asthma or COPD. Of note, they didn't actually have to have a current exacerbation. We think it's a great opportunity to provide education either way, although the majority did have an exacerbation. They were randomized to receive either the in-person strategy or the virtual Teach to Go module. The virtual Teach to Go module is meant to be used by the patient themselves, so what we did in this research study is have the research assistant provide them with the device to use it on, get them set up, because we didn't want to have technology literacy issues and things like that, and then really test the intervention as itself. But other than that, the research assistant did not provide any education. And so we compared that teaching, we compared their inhaler technique before the teaching, immediately after, and then we actually brought them back within 30 days to see whether they were retaining that information. So that was sort of the outline of our methods.
Great. I'm going to welcome viewer Liam Edgar, who's joined us. Welcome. We're talking about virtual versus in-person inhaler education for inpatients or hospitalized patients with obstructive lung disease. So great. So it looks like this was a non-inferiority trial. That was the main goal here?
Yeah. So the choice of the research design was this initial test was to see, could this virtual strategy work as effectively or nearly as effectively as in person for that initial teaching. We didn't expect a one dose of this educational strategy to be better than in person. So we use the non-inferiority for that reason. Now, should we move forward with a multi-dose strategy, we would probably use a superiority design in that instance.
Okay, interesting. So we've got a question from a viewer. Is the root cause a problem with education or the design issues, like how MDIs are designed?
It's both. I would say that it's a large part in the design of the inhalers, and not there's really no way to get around it. There are medications that have been studied and found to be very efficacious if delivered to the lungs. But with the meter dose inhaler, it's pressurized. So how do you space it? That's why we use aero chambers or spacers, but those don't always get to patients and they don't always use them if they do. Dry powder inhalers need to be actuated and brought in with a strong breath. Not all patients have that strength. So it's not, though there's some great design out there that hasn't been developed yet, but there are design flaws built into each device. But we believe with teaching that we can get around that with our tips and our best strategies to help them get enough of the medicine into their lungs.
Okay, interesting. And then, sorry, and we were too fast on it. That was from viewer Matt Loxton. Matt, thanks for the question.
One thing I just wanted to clarify was in this study, the sort of the virtual teach-to-go intervention, that was a one-time intervention, correct? So they got the tablet in the inpatient setting. They watched the sort of instructions, and then you kind of followed up. And the reason I ask is because I think, one, I thought this was fantastic, but secondly, because I would think that one of the benefits of having sort of a virtual model is that people forget. I mean, I often forget things that people tell me, and you're in the hospital, you're sick. Trying to remember all of those instructions might be difficult. So with the virtual model, you can go back to it later on. I think would be an advantage.
Oh, absolutely. I really love that you made that point. Yes, to clarify, each participant that was enrolled got either a one-time round of the in-person teach-to-goal, meaning that research assistant and the patient went back and forth in that one session, or the virtual teach-to-goal, they completed the whole module, which did include multiple rounds of watching the video demonstration in that one session, but it was one session each. This was really meant to get that needed prelim data to move forward with exactly what you're talking about. And I actually have an RO3 from the NIH right now to study exactly what you're talking about. So patients are being enrolled, they're getting their initial session in the hospital setting, and they're being sent home to do this at home. And we're simply testing whether it's feasible and whether patients will do it and whether there's some baseline efficacy.
Yeah.
That's fantastic.
Great. Going to welcome Austin Meyer, who joined us as well. Do you have another question?
I did. Sorry. I'm wondering, and I think you alluded to it a little bit, sort of what was the role, or were there any concerns surrounding digital health literacy, I guess, if that's the right term, and how you get around that? It sounds like in this study that there were measures put in place to ensure that that wasn't a barrier, but I can also imagine sort of looking forward that might be an issue that would come up.
Yeah, no, that is of great interest. In fact, in developing this intervention, we actually worked with several focus groups. So we had about 8 focus groups with real patients with both asthma and COPD to get input from them. Everything from how they wanted the information to be available to them, what device, size of device, fonts, all kinds of details to optimize the intervention. But then in actual implementation use, that's what we're studying right now is, do patients even have Wi-Fi? Or if they have Wi-Fi, do they know how to connect it? Are they using the device they said they were going to use? Is it too small if they're using a screen, or do they not want to use their data? So in a separate study, I actually do an inpatient survey of patients, and we've been for years now assessing patients' technology access, willing to use, and then also their families' accessibility. So one of our main goals is engaging family or other caregiver to work on learning these devices with them. And it's very common in the pediatric world where we teach patients too if the kids are too young, but there's no reason why we can't involve family. So we are finding that the majority of our patients report to us that they have accessibility to technology and even willingness. We will see if that pans out in real life as we're enrolling in this current study.
Yeah, and we've got eFigure 2, which shows some screenshots from the virtual Teach-to-Goal program, which is really interesting. I like how it's a mixture of kind of looks like written slides as well as visual aids, which is nice. I think it kind of meets patients where they are.
Thank you. Yeah.
Yeah, no, go ahead.
I was just going to describe it a little bit. Yeah, we actually have a narrator. She's not in this screenshots here. She's a professional narrator, so she introduces them to what's going to happen. So it doesn't just start, explains what we're doing, and then you see the screenshot of the gentleman there. He's actually doing the demonstration while there are words on the screen and the narrator saying what he's doing. And then the other text are either informational slides or the actual questions that they're answering to kind of help guide whether they need to go through the video again.
Nice, great. So tell us what you found. What were the findings here? It looks like this is one of those things where you could slice it a few different ways.
Yes. Yeah, I mean, I think our goal was to be able to say virtual teach to goal is not inferior to in-person teach to goal. But like many studies, it's not that clean. Many years ago, we actually submitted this before all of our data was in with some of our preliminary studies. So we used a very conservative non-inferiority margin. And unlike in superior margins where their standard p-values like less than 0.05, for each non-inferiority trial, you have to pick something ahead of time as your goal. So that was our margin. We hit the margin exactly, but if you look at confidence intervals, you don't get kind of that p-value significance. So there are ways to evaluate, and we've done multiple evaluations. We try to be as transparent as possible. What we do feel comfortable saying is, at least in this study, that it seems to be nearly as effective, and there's no evidence to suggest that it's not effective and couldn't be studied further and possibly used in real practice.
Yeah, and I think I appreciated your honesty about the trial. One of the lines I loved is although a standard sample size calculation for establishing non-inferiority would result in a larger sample size, the available resources precluded performing a larger trial, and that's just realistic about how these things are.
Right.
And similarly, I think that I'm very far from being an expert on non-inferiority, and I think there's a lot of opportunities for shenanigans with non-inferiority in some of the bigger and industry-funded trials and things like that. But the two things that stood out here is one is it can really be arbitrary about just picking a non-inferiority margin. A lot of times you don't really know, and as you alluded to, sometimes as you find out more information, you realize the number you pick may not be the right number.
Yeah.
And the second thing is this really strikes me as a perfect example for non-inferiority, where you're not going to expect people to do better than the alternative, but there are big advantages. Like you don't need staff; you just need somebody to have access on their phone or their iPad that they already have. Which is great.
Yeah, and the true study was also alluded to before is the real intervention with the virtual is the multiple dosing availability. So a real world implementation study where you're looking at, the example I often give is hand washing. So soap and water may be more effective or efficacious than Purell, but if people never wash their hands, it's not effective. So if people can get technology literacy and technology access issues aside, this module more readily, then maybe it would be overall more effective, or at least as effective.
Yeah,
makes sense.
Yeah. To borrow from my wife, who's a dietitian, who I quote her on this all the time, is the best diet is the one you actually do.
Yes.
The best exercise is the exercise that you actually do. No. So that's very realistic. All right. So any final thoughts before we finish up here?
No, other than just thank you so much for this opportunity. Any chance that I get to kind of share, I think the main takeaway here is inhalers are really hard to use, and we just need to work with our patients to use them better.
Well, wise words.
Yes. Yep, absolutely. Well, thank you so much for joining us, and thanks for the
Thank you.
Thank you. Okay. All right, so we're going to move into our table of contents. We've got Melissa Breger, who's joined us. Welcome. We're moving to our table of contents rundown. The first one we have, I'm going to butcher the pronunciation here. So it's the Association of Physician Peer Influence with Subsequent Physician Adoption and Use of Bevacizumab.
That's right.
Bevacizumab. It's one of the MABs, one of the first biologic cancer agents. It was introduced in, I believe, 2004. Initially approved for colon cancer, but it's now been expanded to most other major cancers. In this study, they looked at previous studies have found that the adoption has kind of been really asymmetric and heterogeneous across the country. And so they try to quantify it a little better using some network analyses this group has done before. So they looked at 51 hospitals across the U.S., about 44,000 Medicare patients with colorectal, lung, breast, kidney, brain, or ovarian cancer, total of nearly 3,300 oncologists, and basically broke it down from the beginning of the 2004-2005 period, where only a handful of the patients had received bevacizumab. broke the providers up into tertiles or thirds of kind of low, medium, or high utilizers, and then compared later on how people joined and whether or not they had been exposed to peers or peer networks or communities of practice who had used it previously. And basically the punchline is they found that doctors who knew doctors who used it were more likely to use it, which is one of the things that's both kind of ingenious and kind of has some great face validity. That if you're in communities of practice where people are doing a thing, you're more likely to do the thing. I think for me, one of the big examples that sticks out is tranexamic acid. People in emergency medicine, people on Twitter are much more likely to use TXA. and part of it's just, hey, I have a great experience. For me, it's been, kind of the low acuity stuff like nosebleeds and dental bleeding that's been really helpful for. And it's safe and effective, whatever it is. And part of it's just knowing people who use it and familiarity and me talking to colleagues about it and that sort of thing.
Yeah, I think it makes sense. I thought this was so cool. It was just so interesting to think about it. And I love this line that the authors say, this suggests that the adoption of bevacizumab is a complex contagion needing social reinforcement rather than simple contagion, needing simple informational contact only. So I think that really, it's essentially summarizing what you've said, but it really makes a lot of sense to me that, even when we have all of this great data about how good or, how efficacious something is, until a lot of people around you are using it, maybe it may not end up being used to its full extent that it can be. So really interesting.
Yeah, exactly. And the invited commentary that come along with this talked a lot about simple versus complex contagion, and basically how what you're getting at, where it's just just not, there's a study, we prove therapy works, and therefore everybody does the therapy. That's not at all how things work. That's basically why we're here right now.
Yeah. I'm wondering, I think this was sort of in the community. So I don't know that they looked at, for example, if it was in a teaching hospital, if there were certain attendings and then they're teaching that to their residents and fellows, and that, if that played into it at all. But I think even, apart from that, there definitely is some validity to this.
Yeah, and that was one of the other things that I found interesting is they used 51 hospitals across the U.S. and they found 252 communities of practice within those hospitals overall. Right. And some of that is probably just systems, it's like breast cancer, which is much more likely to be surgical, or ovarian cancer with gynecologists or gynecology oncologists, et cetera. So there's kind of the little, silos with some crossover inside the hospitals. But yeah, this stuff's really interesting. I think and again, it's just one of those things that just rings so true when you think about it. Gonna welcome our previous common viewer, Min Lakong, good friend of mine. Welcome, Min. Thanks for joining us. You missed the TXA part, sorry. So what do you have next?
So this is a comparison of risk of recrudescent fever in children with Kawasaki disease treated with intravenous immunoglobulin and low-dose versus high-dose aspirin. So I always love studies about Kawasaki's disease because I feel like it's something that always comes up in med school and also on the ID boards, interestingly enough. So this was a retrospective cohort study looking at 260 children with Kawasaki's disease in a single center in Indianapolis. And the premise here is that aspirin plus IVIG is used to treat Kawasaki disease, but the dose of aspirin hasn't been thoroughly explored. And so they looked at patients that had received high-dose aspirin, so this is greater than or equal to 10 milligrams per kilogram per day, versus low-dose, which was less than 10 milligrams per kilogram per day. And their primary outcome was looking at which patients ended up having sort of recrudescent fevers needing retreatment, essentially, for Kawasaki's. And they found that, so overall, a little more than half of all of the patients with Kawasaki's disease were treated with low-dose aspirin. Interestingly, actually, over time, this changed. So the primarily low-dose aspirin was used before 2016, and most of the high-dose aspirin that was used was actually after 2015. And this is demonstrated in the figure, which was just kind of, there wasn't really an explanation, so I was wondering, what that was about.
But, it's a complex contagion of community
right,
practice.
exactly. There you go. It's all coming together. Right. And they actually found in this study that there wasn't any significant association between recrudescent fever and aspirin dose. They also did a subset analysis of patients that had what they call complete Kawasaki disease, and they found that the odds of recrudescent fever with low-dose aspirin was actually higher in this subset analysis, but this did not achieve statistical significance. A secondary outcome, which I thought was sort of interesting, they also looked at the association between treatment dose and coronary artery abnormalities, or also length of stay, and there was also no association found between treatment dose and those outcomes. So sort of interesting. I don't know if there's a cost difference between low dose and high dose aspirin, or certainly I'm sure that there are other potential adverse effects using high dose aspirin for long periods of time, but something to think about, I guess.
Yeah, I mean, the things that I found most interesting here, in addition to everything you said, well, for one, they had 670 patients over the decade or so at this one center,
right.
Which is amazing. I mean, it is Indiana University, which is one big regional referral center in a pretty big flat open area. And also the difference between the high dose and low dose aspirin, the typical doses were basically 3 to 5 mg per kg per day versus 50 to 100 mg per kg per day.
I know, it's such a difference.
Right.
Yeah.
But also an adult dose is 50 to 100. I guess 50 to 100 mg per kg. That's basically a baby asprin for every kilogram.
Yeah, right,
That's a lot of aspirin. And also just the rates of it was about 8% of coronary abnormalities, or 8% of patients in the study had coronary abnormalities. I thought I had a patient with Kawasaki's a few months ago, but it turned out it was not. A staph scalded skin.
Oh, no.
Yeah, she did well, though.
Oh, good. Okay.
All right. So moving on, we've got an interesting research letter evaluating the trends of near real-time urine drug test results for methamphetamine, cocaine, heroin, and fentanyl. This is from the same group that we covered back in April before you joined us with Michael, where they looked at fentanyl co-ingestions on urine drug screens, or urine drug tests, excuse me. So the first thing is this is definitive urine drug testing, not the urine drug screens that we see in emergency departments a lot of the time, that people like me rail against for being horribly inaccurate. This is definitive. It's the LC-MS testing, where they're doing official testing of molecules and not just the simple antibody stuff. If you look at the graph, this is where pretty much all the money is. The methamphetamine is the yellow, cocaine's the black, heroin's the blue, and the fentanyl is the gray. And you can basically see there's a lot of everything. The first half of the graph, the part of figure A, shows that the testing has gone up, and whether that's because people are using drugs more or doctors are sending this urine for testing more accurately, it's hard to say, but probably based on what we've seen with mortality data and things like that, probably mostly increase in actual use. And then for me, what's more interesting is how much the fentanyl positivity has gone up, which in figure B, which basically, quarter to a third of all drugs tested or all the fentanyl had other stuff in it. So not only is fentanyl in everything now, but there's a lot more kind of co-ingestion, and basically, there's nothing is pure and unadulterated anymore, and basically you just can't trust street drugs.
Yeah. I wanted to ask you, as I was reading this, I was thinking about you because I just, in terms of your experience, as someone sort of in the ER, like does this sort of ring true to you and potentially your colleagues as well?
Yeah, I mean, we've certainly seen, I basically, I forget where I stole this from, but stopped using the word heroin overdose because there's just, at least 2/3, 3/4 of the stuff out there has fentanyl or fentanyl analogs in it. Everything's an opiate overdose now. We're just seeing that even with standard, what people think, the chances of whatever people are using having fentanyl or fentanyl analog adulterants in it is so high that just the chances of unintentional overdose are so much higher now with everything. And we're also seeing, just higher dose of Narcan are needed. I used to be really skeptical of Narcan nebulized Narcan because it just doesn't seem really helpful that if you're breathing enough to get the nebulizer, do you really need the Narcan? But not necessarily for patient-oriented differences of the patient needs it to breathe, but more just they need the nurse or me going over and nudging them less over a period of time. It's been very helpful. But yeah, I mean, basically we've seen the data, we've seen the numbers. It rings true with it really resonates with our experience that there's just a lot of fentanyl in the illicit drugs now.
Do you think that any of this could reflect just changing preferences too, potentially?
Yeah, and that's actually something we spoke a lot with the author last time on the other paper, was that it's very hard to know how much of this is adulteration versus people intentionally using, say, meth plus fentanyl for the speedball effect, the kind of upper and downer combination.
Yeah.
And we don't really know from this. It's hard to really say. But from all the data we've seen, from everything else we know, there's very few things out there that just don't have some sort of fentanyl added to it.
Yeah, interesting. Yeah. Unfortunate.
Yeah, it's unfortunate, but new opportunities to solve.
There's that optimism bringing in 2020.
Right. We've got a viewer, Miguel Achada, who's joined us. Welcome. We've got one more paper to talk about. What do we got?
Yeah, so this is a research letter, participation in a hospital incentive program for follow-up treatment for opioid use disorder. This was really cool. This is like a behavioral economics almost kind of thing. And so they were looking at, essentially the Pennsylvania Department of Human Services started an incentive program to try to improve the rates of opioid use disorder follow-up treatment among specifically Medicaid recipients. And so they had these sort of 4 pathways that had been set out. ED initiation of buprenorphine treatment, a warm handoff to community resources, referral and treatment for pregnant patients, and then inpatient initiation of medication. And so they had these sort of various grades of hospitals, and achieving various paths would lead you to receiving financial compensation, essentially. And so so this study was looking at the hospitals that achieved parts of the path or all of the pathways, and if the incentive, essentially kind of like how it worked. And so this was a cross-sectional analysis. Excuse me. They looked at 155 hospitals across Pennsylvania, ultimately found that a little more than half of those hospitals participating attested to all 4 pathways. In their adjusted model, they found that among those hospitals that were full participants in the pathways, they tended to be larger hospitals, hospitals that were affiliated with large health systems, in the southeast region of the state, as well as central and west, and also in hospitals with counties that had higher overdose rates, actually. And the other thing that I found was kind of interesting about this was the study also found that more hospitals overall were actually willing to arrange the warm handoff to community resources rather than actually initiating treatment in the hospital for opioid use disorder, which to me actually does ring true. And I think part of that, I think part of that is also sort of evident in, who ended up being a full participant. I think hospitals that have more resources that are able to do, initiate treatment appropriately and have some sort of, either a unit or a team that kind of is able to do this, it's probably going to be more successful overall. That's just sort of my conjecture, but I think it kind of makes sense.
Yeah, absolutely. So going to welcome Carlos Luz and Yu Soy, who've joined us. Welcome. We're talking about the Pennsylvania incentive program for follow-up for treatment for opioid use disorder. And yeah, it's really interesting. I think there's a couple different ways to look at the inpatient medication treatment and how very few hospitals participated on that front. One, I think, it's a big lift to make a program like that.
Yes.
You need to do a lot of comprehensive things to do inpatient treatment. There's a lot of reasons why people don't, but also, it's not necessarily shirking responsibility to turn to experts or programs or existing programs or institutions that are already doing it and already have the expertise in it, already have experience with it, know where the pitfalls are, know how to make the numbers work, that sort of thing. In my department, we are working on getting all our providers X-waivered to be able to prescribe buprenorphine. I'm in what I think are the final stages of doing it.
Oh, great.
And it's one of those things where it's this horrible paradox and basically a regulatory failure at this point where I can prescribe pretty much as much opioids as I want, but I need to do 8 hours of training and a fair amount of paperwork and things like that to be able to be certified to prescribe buprenorphine to treat people who get addicted to the opioids.
Right. There's a discordance there, definitely. Yeah. And, I think that, and I'm sure that I've actually seen studies too, that part of it is that some people just don't feel comfortable. Practitioners don't always feel comfortable in initiating it. But actually, once you go through the training, you realize, it's actually not so difficult.
And the training's not that hard.
No.
And it's not that big of a lift of the training. And it's also really, it's one of my colleagues who was leading our training, who's a toxicologist. It's basically all the questions are like, the answer is just always give them buprenorphine.
Yeah.
It's not that hard. And we've all been, doing boards like it's really not that hard. Afterwards, I was talking to one of my other colleagues about it, and I was like, am I missing the point, or is this really just give Boop start at 4 days? It's not that big a deal. Bup is much safer than most of the other things you do. One of the other things I found interesting was, looking at the numbers that only half of hospitals did all 4, and a quarter or a fifth, did none. But when you break down how many did each of the 4 different options, it's 60%, 80%, 80%, and 60%.
Yes, I thought that was interesting.
Which is all pretty good. And Steve Finn, the deputy editor for JEMA Network Open, always talks about this. If you ask how many people did 100% of all of these things, it's never going to look good.
No, right,
it always
exactly.
Looks bad when you do that stuff. So these individual ones look really good. Again, inpatient medication treatment for opioid use disorder is hard to set up. There's a lot of reasons why people either can't or won't do that. And getting this stuff is pretty good. I'm actually surprised that they did better with the referral and treatment and warm handoff than with starting buprenorphine. It's really not that hard to get people X-waivered.
Yeah. But it's again, if you don't have the resources or you don't have the capabilities, sometimes there's so many things that inpatients, hospital teams have to do. So it's unfortunate, but
but it's good. It's again, not to be too cheesy about it, but I think that the amount that we've seen the pendulum swing in our addressing the opioid epidemic has been great. Again, we're seeing, this is, a lot of emergency departments are introducing this sort of thing. A lot of hospitals are embracing it. Making gross generalizations based on my limited knowledge of Pennsylvania geography. It's basically the Philly area and the Pittsburgh area that have big integrated health systems that are doing it. And that's again, it's the larger systems, the larger hospitals that have bigger integrated systems that are doing this better.
Yeah.
So
I think that makes sense, and yeah.
Yeah, absolutely. Great. Well, thank you for joining us. Of course, you can get these articles and more free and open access at JAMANetworkOpen.com. Look for our new releases every Wednesday and Friday at 10 a.m. Central Time. And join us next week, Tuesday at 3 p.m. Central Time. Follow us on all the usual social media channels at JAMA Network Open. And, of course, subscribe on iTunes wherever you get podcasts to our podcast. And you can get the author interview portions of these episodes as well.
Take care.
Great. Take care.
Bye.
Thanks.